on this computer. All right. So I can't see you all, but that's all right. I don't care if I see you all or not. Okay. So when we're talking about the chest tube setup, so we just got it put in and we put the dressing on the patient. So now we've got this chest tube system that's going here. The chest tube system will have the drainage system here on the right. It will have an underwater seal in the middle, and on the left will be your suction compartment. Now, there are two kinds of chest tube drainage systems. Some of them will have a water system, which is the one that I described, where you pop the little top off and fill with water. Some of them will be a dry system. Now, all of them will have an underwater seal. All of them, you will have to put the water in the middle section. But when they talk about a dry system, it only pertains to the suction chamber. Some of them will have a little valve over there that's a little orange valve that you can just dial in that says 20, 30, 15, 5. And a lot of the units on the adult side use the dry suction. So you won't have to fill it up over at the hospital. However, NCLEX tests about the wet suction, the one that you have to fill. So that is the one that we will also test on. So when you go to your preceptorship, you may see that it's a dry suction over there. So when we're talking about the suction side over there, you fill it according to how much suction the doctor wants the patient to have. You do not have to have suction. You can have it just to straight gravity if you wanted it to. But most of the time they do put it to suction, but it doesn't have to be. When you fill it up to how much suction the doctor has ordered, it's not on. The best way I can compare it is to your stove. You say, I want the stove to be set at 350 degrees, but until you hit the bake, your stove isn't on. Well, it's the same thing with your atrium or your chest tube drainage system. Filling it to 20 doesn't turn it on. You've got to hook it to suction. So on the top of your suction unit, and this one just shows a little spike here, a little spike right here. But in reality, and I can't see myself, so I don't know if y'all can see it or not, but I'll hold it right in front. It's the little short tube again that's coming out of the spike here. This is hooked to a regular setup to the suction on the wall. Now, it should be a clean suction. This is the same suction you used for NG drainage. It's the same suction that you used for to suction a trach out, but it's just an empty suction canister hooked to a regular old suction on the wall. And you just take your suction tubing, but instead of it being plugged into an NG tube or being plugged into a Kaplan sleeve, you plug it into the short side. And when you plug it into the short side, the suction chamber will start to bubble. When it is bubbling, it means it is on. So the amount of suction is based upon how much water is in it. Turning it off and on, that's all it is, off and on, is done by hooking it to the wall. Okay? Now you can disconnect this from the wall. So if the patient wants to go for a walk, you can disconnect it and they can pick it up and carry it. Just like a Foley, you take your Foley bag with you. Just like an NG, you can disconnect your NG from suction. You don't take the NG out of their nose, that you disconnect it and they can go for a walk and then they come back and you hook them back to suction. You can disconnect this from suction and there's no problem. And then when they come back, you rehook them to suction. Okay? They're still hooked to the chest tube to their chest, but they can disconnect from suction and there's no problem with that. Okay, I have a picture. The next one is a picture of the chest tube setup that is a valve. So there's not that big thing that has the canister you have to fill, but in this case, and there's just a little thing on the side that you dial. This would be to 20 centimeters. This would be to 10. This would be to 30. This would be to 40. So you can actually just dial around what you want instead of filling it up. But then you still have to go back and hook it to the wall to make it work. And what happens is this little orange thing right here, it's a bellows. It's flat. And then when you hook it to suction, it comes across, it blows it up. And that's how you know what it is, that it's ready to go. Okay. So what is the nursing responsibilities when a patient has a chest tube? Well, you're supposed to document the status of the chest tube at least every 2 hours. You go into your electronic charting and you fill out the section on the chest tube every 2 hours. And the questions that they ask about it. They're going to ask you to assess the respiratory status and that the chest tube system is working properly. They never move off of vital signs every 4 hours. So they have complete sets of vital signs every 4 hours. And you're always noting the respiratory status every 2 hours in their electronic charting. You're going to check your drainage system every hour. Just like when you walk in and see a Foley, just look at it. Just make sure it's okay. It's kept below the level of the chest, because if you raise it above the level of the chest, then it's going to flow back into the patient's chest, the drainage, and you don't want that. We're trying to clear it out of the chest. You don't want them to have any kinks or real dependent loops that people can trip over or anything. So typically, you run this down the bed and keep this near the foot of the bed instead of I don't know if you can see. This tube, I don't know how long this tube is, but it's, I don't know, 5 feet maybe, 6 feet maybe. It's a pretty long tube. So if I was to have it right at my chest and put this right next to me, this would just be a big bunch of tubing laying right next to my chest. So I would have a lot of loops for people to trip over, and drainage would just collect in this tube all the time. So you really want to put this down by the foot of the bed. And so people aren't going to trip over this tubing. It's just not going to be laying on the floor for people to walk on and step on and trip on. So you really don't want a lot of dependent loops with this. Typically, there's only one connection. It's right here. And so we typically put tape around it and make sure that it's taped into the chest tube really, really well. You're always looking at the drainage. The drainage is going to go from bright red to dark red to sort of sear sanguineous to just a straw-colored type drainage. It's going to decrease in amount. Every single day, you'll have less and less and less, right? Keep your patient calm. If they need something for pain, it's not a terribly painful thing, but it's just kind of this nagging sensation in their chest all the time. But it's not extremely, extremely painful that you have to deal with all the time. You're going to check for fluctuation in the underwater seal in the middle chamber. You're going to check for this chamber to move. It goes up and down with each breath. For it to go up and down is expected. It is normal. Bubbling is not normal. And I have a video, and even if we don't have the sound, and I don't think there is sound, I did share my sound on this time. I practiced during lunch, but I don't think there's sound on the video. But I want y'all to watch it anyway. It's not a long video, okay? But so where's my little thing? I practiced. There it is. So I want y'all to watch this. So you can see on the side, we're looking at the underwater seal. When you all filled it up to that line where it says 2 centimeters, the water turned blue.
As with any chest drainage system, the drain must be placed below the level of the patient's chest and kept in an upright position to maximize drainage efficiency.
We can hear it.
All patient tubes and suction connections should be routinely checked to ensure proper leak-proof operation and chest tube patency. Depending upon your hospital's preferred sampling technique, samples of drainage fluid can be taken directly from the patient tube by forming a temporary dependent loop and inserting a 20-gauge or smaller needle with syringe at a shallow angle. On selected models, Samples can be taken directly from the needleless Lure-Lock sampling port located on the patient tube connector. A water seal is a simple one-way valve which allows air to exit the chest and prevents air from returning to the patient under normal conditions. It's also a very useful diagnostic tool, as it can show even the smallest trends of an air leak, as well as changes in intrathoracic pressure. Assessing patient air leaks is easy with Atrium's Blue Tint Water and Air Leak Monitor. Continuous bubbling observed in the water seal will confirm a persistent air leak in either the patient's thoracic cavity or possible tube connections. Intermittent bubbling with gentle float ball oscillation will confirm the presence of an intermittent air leak. And no bubbling with minimal float ball oscillation at the bottom of the water seal indicates that no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. When monitoring a chest drainage system, it's important to maintain constant gentle suction control bubbling and to periodically check and adjust the water levels in both the suction control chamber and water seal during system operation as required. In the event of an accidental knockover, place the drain in an upright position immediately and check for interchamber spillover and correct fluid levels. Both suction control and water seal fluid levels may be adjusted as necessary.
Okay. Okay, so you need to check for the bubbling in the underwater seal. That is abnormal. That means air is still coming out of the alveoli. There's still a hole there. If the tube was to get pulled, then they would collect a pocket of air again. So an air, that's called an air leak. So that is abnormal. So every shift you go in there and you say, okay, Mr. Jones, I'm going to check. We're going to do our check here. And where you're looking is in the underwater seal. And you say, okay, Mr. Jones, take a good deep breath for me. And you see if there's bubble right there. Now give me a cough. You look right there. Then you help them turn on their left side. And you say, give me a good deep breath, Mr. Jones. And you look, give me a cough. Then you help them turn on their right side. And you say, give me a good deep breath. Now give me a cough. And that's where you're looking. Now you saw the bubbling in the drainage, in the suction chamber. That is normal. That means the suction is on. So your role in that is to disconnect. The doc, I know that they should be on 20 centimeters of water pressure. Is my level at 20? Well, no, my level's down here somewhere. Then I need to refill it because it does evaporate off some. So if they've had it in for 3 or 4 days, I would suspect that there's been some evaporation because bubble, it evaporates. So you always want to make sure that it's correct. But you can't do that when it's on. Just take it off, check your amount, refill it if you need to. If you don't, then yes, it is at 20. Then just put your suction back on it. So what's the characteristics of my drainage? Every shift, and I couldn't hear. My computer must be set up to need earphones. You come at the end of your shift and you mark it. You don't open it up because if you open it up, they'll breathe through the tube and it'll collapse their lung again. So you come at the end of your shift, and this is made to mark on with pencil or pen. You mark it, and you say, 2/8, whatever the date is. I don't know what day it is. And you mark it. The next shift comes in and marks where theirs is and puts the date and the time. The next shift and subtracts the amount, and that's where they put it on their I&O. Then the next shift comes in and marks theirs and says date and time, and that's what they put on their I&O, the difference between the last mark. Then the next shift comes in, and what's the difference? And you just keep adding it in, but you don't open it up. So that's how you care for it. Okay, so keep it functioning, keep controlling gauze around the tube. Most units, you do not change the chest tube dressing unless it's wet, leaking, or it's come off. Typically, we just leave it on unless there's a need to change it. It's not a routine change. Keep your tubing free of loops and kinks. good pulmonary toilet. We want them to turn, cough, deep breathe, and use their incentive spirometer. Typically, when just like kind of a Foley, when you go in the room, just give it one of these. Just keep the tubing clear, empty it down, and make sure it's always sitting up. If the container gets knocked over, just sit it up. It'll maintain its water seal once you set it back up on its feet. Just sit it back up. If it's okay, if it gets knocked over, it's not a big deal. Just sit it up. Okay. Talk to your patient. They might be scared of their chest tube. Tell them what it is. This is just keeping your lung inflated. It is not a ventilator. It's not making them breathe. It is inflating it's helping their lungs stay inflated. It goes into their chest about 6 inches. It's not just sitting right at the edge. It's not going to be easy to come out. So yes, they can lay on it. Yes, they can get up and walk. Yes, they can turn all different directions in the bed. It's not pulled out easily. It's sutured in place with big, thick silk suture. So it's not going to come out. Move, cough, get up, walk, sit in a chair, walk. Okay. We expect bright red bleeding for about 72 hours, and then it should start getting dark and just start clearing into straw colored after that. And let them know, I'll be watching. I'll check you real frequently. Don't you worry. Okay. After about 3 to 5 days, they'll start. And if the lung is inflated and they'll see that on chest x-ray, it'll be time to take the tube out. And what they'll do is we'll give them a little Lortab or something about 30 minutes before it's time to take the tube out. The doctor takes the tube, or the healthcare provider, like a advanced practitioner, will take it out, like a PA or a nurse practitioner will come up to take it out. They'll have the patient Valsalva and hold their breath, because I don't want them taking a breath when I take the tube out. So I'll have them bear down, and then they'll clip the sutures first. They'll have a Vaseline gauze under some gauze, like under some 4x4s, and they'll say, okay, take a deep breath, bear down, and they'll jerk that tube out. And the patient will go, oh, ooh, that feels good. And then they'll just put that Vaseline gauze over the hole so there's no air going back up in the hole. And they'll just put some of that Elastoplast tape over it again. And that'll just stay in place for an airtight dressing. And then they'll do a repeat chest x-ray to make sure that lung is up. And then you're going to monitor for any respiratory distress, okay? And any drainage on the tube over the next day or so. If the pneumo's back, they'll have to put another tube in. All right? And that's pretty much care of the chest tube.
Jamie, I have a question.
Sure.
If at some point when they have the chest tube in, it comes disconnected from the drainage system, like what are you supposed to do?
Well, typically it won't, but about the only place it can really come disconnected is here. You could take your chest tube and put it under a glass of water, The chest tube itself, just stick it in a glass of water, and you made an underwater seal. The purpose of the underwater seal is so that air can still come down the tube and escape, but they can't breathe air back into the tube. That's what an underwater seal does. So that is what you want to do. If the tube gets pulled out of their body, you just need to put Vaseline gauze over it and call your physician. Assess your patient and call your physician. Put Vaseline gauze over it so that you don't suck air. And if you're lucky, the tube was ready to come out. If you're unlucky, they'll put another tube in. These tubes don't come like these do. They don't come out. That coming out, that problem, the break-in or whatever, was really with chest tubes bottles. They used to break. And then we had a little bit more trouble. These don't break. These don't break. We don't have that problem like we used to. The biggest would be if they came out, then slap Vaseline gauze over it and a dressing. And then you got to assess your patient and call your doctor. Just make sure your patient didn't have any severe respiratory distress.
Janie, if they're able to get up and walk around the halls and do things with their chest tube, how long are they able to be off the suction?
Oh,
Like,
forever, forever. They don't even have to be on suction.
Oh, okay.
So there is no time limit for suction. So if they want to go for 2 hours for a good long walk, they won't do that. But if they wanted to, it's fine. There's no time limit for being off the suction. And as I said, some patients aren't ever on suction. The doc may just say chest tube to underwater seal, no suction. All will be onto underwater seal, all. Suction is sort of immaterial if the doc wants some or not.
Got it.
Most are on suction, but that really doesn't affect a whole lot. It just gives it a little bit extra pull. Okay. Other questions? Okay. Real quick, pulmonary contusion is simply a bruise. And you know, a bruise is when the capillary bed is broken and blood went out into the tissues. Well, where the capillary bed is broken, then gas exchange doesn't take place at that capillary bed. So a lot depends on how big a bruise is it. And you know, if it's a small bruise, then probably there's no symptoms at all. The bigger the bruise, that means the more gas exchange that doesn't take place. So it's really related to how big a pulmonary contusion is it. If it's just a little one, we don't do anything. If it's like a whole lung, then it could be up to being intubated. So it all depends on how big a bruise it is and how much hypoxia is present because the lung itself is damaged. But it all is resulting in hypoxia because gas exchange doesn't take place where the bruise is. The capillary bed, it doesn't go through. The capillary bed is where gas exchange takes place. And that capillary bed is gone. It'll heal back. But for that point in time, it's gone.
Janie, you're talking about a bruise on the lung itself, not like this.
Bruise on the lung itself, not in the tissue around on your skin, but on the lung itself.
How do they diagnose that? Because you can't really.
They'll see it. They will see it on a chest X-ray. It looks a little different than water does. It looks a little denser than water. They'll see fluid, but it looks a little denser than water. It looks more like blood than water.
Okay, thank you.
Mm-hmm. It's blood. It's not water. It's not pulmonary edema. It's blood. So it has a different color. Of course, X-rays are black and white, but it's shades of white, gray, and black. There's different shades, I guess is a better way to say it. When I say color, it's different shades of black, white, or gray. So it's all depending on how much and how big a bruise it is and how hypoxic are they is how we treat it. We're treating the hypoxia. We really can't treat the bruise. It has to heal on its own. Okay? Is that it? Okay, so now, shock. There's lots of different kinds of shock. The definition of shock is inadequate tissue perfusion. The tissues do not get enough blood flow to them. It is a blood flow problem. It is a perfusion problem. So far, you have learned about hemorrhagic shock, meaning that there was enough, you're losing red blood cells due to hemorrhaging. You've learned hypovolemic, which means you've lost fluid. It can have red blood cells in it. It doesn't have to have red blood cells in it. It could just be the plasma part, like with burns. Hemorrhagic is a type of hypovolemic shock. You've learned neurogenic shock. It is due to transection of the spinal cord, which causes the inability to have sympathetic nervous stimulation. The spinal cord won't let you secrete epinephrine, won't let your brain say vasoconstrict, so you vasodilate and you pull your blood out in your extremities so that it doesn't come back up. And so you become bradycardic, you become warm, you become hot, but your cardiac output falls because your blood is pooling out in your extremities because you can't do fight or flight. The pathways for fight or flight is not there. So you become underperfused. You become bradycardic and hypotensive. It's the only one that causes bradycardia is neurogenic shock. All the rest of them cause tachycardia. But it's the only one that causes bradycardia. It's the only one that causes you to be warm. All the rest of them are pale, cold, and clammy. You're going to learn anaphylaxis next Tuesday, and now we're going to do septic, and then Jane will cover cardiogenic. But all of them are impaired tissue perfusion. For some reason, your tissues do not get the right blood flow to them. For some reason. Hemorrhagic, because the red blood cells aren't there. Hypovolemic, because the volume is lost somewhere. Neurogenic, because the spinal cord has been transected. Septic, because you have a bacteria that causes it. Cardiogenic, there's something wrong with your heart. Anaphylactic, because you have an antigen-antibody reaction. So there's a reason, but whatever the reason was, you have impaired tissue perfusion. They all result in impaired tissue perfusion. Now, shock has 3 stages, okay? And the initial stage, most of us don't even recognize it. We get a little lactic acid buildup. We might get a little thirsty. We may not feel real good. And we may be in a little bit of shock. And typically, we might fix it. We might sit down. We might rest. We might go in there and drink something. We might get it fixed pretty well. And we may not even recognize it. We probably will not seek treatment for initial stage of shock. That is not where we show up at the doctor's office. If the body fixes itself, then we reverse it. If we don't get fixed, we will go into the body will try to start to correct it. We will start to compensate. There's basically 3 ways that we start to compensate. We'll do it neurally, we'll do it chemically, or our endocrine system will do it, okay? Endocrine you learned in A&P. The most common one is your renin-aldosterone system. Your kidneys will start to quit peeing out fluid and make you reabsorb the fluid back into your circulating blood volume. Aldosterone increases your circulating blood volume instead of peeing it out, okay? You all know what your glucocorticoids do from your adrenals. Those of you with Cushing's disease, those that you give steroids to, don't they get moon face, buffalo hump? Don't they gain weight? Your glucocorticoids will start to keep the fluids in you. So your body is going to increase your glucocorticoids, your cortisol. It's going to make you keep fluids on board. So, and then your adrenal medulla is another part of it, but it does some things with epinephrine also, like with your, when Jane talked about your pheochromocytomas, that's a tumor, but it affects in the adrenal medulla, it affects the epinephrine, which is going to affect your blood pressure. But my point becomes your endocrine system has a way to help you to perfuse by either increasing your circulating blood volume or causing some vasoconstriction in your body. So that was your endocrine system. I'm not covering endocrine any more than that because Jane has already covered your endocrine system, okay? And your A&P covered more endocrine system. And I've even already talked about your neuro and, in a way, your chemicals. You have some special tissues in your carotid bodies and your aortic arch, and these are called baroreceptors. They are pressor receptors and chemoreceptors. And they say, the pressor receptors say, I think there wasn't as much blood flow past me. I did not feel the same pressure going past me. That's why they are called pressor receptors. I did not feel the same pressure. So I think, brain, I'll send the signal up to the brain. Brain, why don't you send down some sympathetic nervous stimulation, send down some epinephrine, and cause some vasoconstriction starting in the periphery, and we'll vasoconstrict down and shut some blood up to the heart, the lungs, the head, a little to the kidneys. And that's really where I need it. So why don't you increase my vasoconstriction, which is going to increase my blood pressure, increase my cardiac output, which will increase my blood pressure, and I'll get more pressure coming out of my heart. Okay? They also have chemoreceptors, because as your cardiac output falls, you tend to have your perfusion falls, so your PO2 tends, when your lungs become underperfused, you tend to become more hypoxic. So your PO2 starts to fall. So at the same time, it's not getting the same pressure, it's not getting the same oxygenation. And so the same sort of tissue says, well, it's not just pressure. I don't think you're as oxygenated as well either. Hey, brain, I think we need to have more blood flow up here too. And so it all goes together. Both chemoreceptors and pressure receptors are all compensatory mechanisms that say, shunt more blood. Along with that, breathe a little faster, speed it all up, a little epinephrine, make your heart rate go a little faster, which also will help with your low PO2, RAD, restlessness, anxiety, tachycardia, and tachypnea. Okay, so all of this is part of your compensatory mechanisms. All right, so your body is in the second stage of shock. So now you're feeling this sort of tachycardia. You're getting more. Maybe you start to feel a little bit different. You know, you can tell something's going on, and probably you're starting to you sort of were feeling a little bit more on the dizzy side, and you probably were starting to seek treatment at this time. You noticed that when you stood up, you were really dizzy when you stood up. You know you've been sick, and maybe you should be seeing the doctor. And a lot of you are seeing the doctors at this time. And this is when they know that you're orthostatic, and they open up fluids on you, and they're starting to fix your perfusion problems. The body has started to compensate, but you're feeling that, and you know something is wrong. You are recognizing something's wrong during the compensatory stage. This is where we would like to fix you. If we fix the underlying problem, usually you will reverse the shock and the patient is absolutely fine. And we usually do fix you at this point. People come in saying, I've been vomiting for 4 days and I'm really dizzy. Okay, a couple liters of normal saline wide open, stop your nausea, stop your vomiting. We'll send you home. You'll be fine. Okay. If it isn't fixed, or if we can't fix it, you will go into the progressive stage. Now we're in trouble. Okay. Compensation continues, worse vasoconstriction, worse tachycardic, worse decreasing of our PO2, worse prolonged everything. And so what happens is we go into anaerobic metabolism. Now, this means that we are going to develop bacteria that normally we don't get. Usually we have good enough PO2s that we don't develop funky bacteria. We get the staph, we get the strep, we get the little normal C. diffs. We get the normal bacteria that use oxygen. But when you become underperfused and you start with anaerobic metabolism because you are underperfused, then you're going to have bacteria start to grow that normally does not grow in your body. And that bacteria is anaerobic and it is tough to treat. It doesn't kill us easily, okay? You also are at great risk for disseminated intravascular coagulation. It's called DIC. Now we're going to cover DIC next because DIC is during the progressive stage, and it's because compensation is failing. The body's not able to get itself out of this underperfused state. And I'm going to cover it in just a second. But if we can't get you out of the progressive state, and most of the time we cannot, you will go into the fourth stage, which is refractory, and you will be unresponsive. Unresponsive to therapy, and you will die. So we want to get you out during the compensatory stage. When you start having symptoms, it's the time to treat it. Because if we can't get you out then, we probably won't get you out. Okay, so what is DIC? What is disseminated intravascular coagulation? It is a hypercoagulable state. It is an increased concentration of your clotting factors. It is a hypercoagulable state. You use up all of your clotting factors. Now, here is what happens. And please understand, I am simplifying this like kindergarten simplifying it. It is much more involved than this. But this is basically what's happening, okay? We've been in the compensatory for a while now. The body's been trying to compensate. So it has vasoconstricted, and right now we're a little chilly, but we got nice, still kind of pink fingers and pink toes and all. But the underlying cause hasn't been taken care of yet. But the body's trying to keep the blood pressure up, okay? So it's tachycardic, but it's vasoconstricting and not really working. So the body's saying hey, blood pressure's still falling, so why don't you send more epinephrine out? So it sends out more epinephrine. So now we're even more cold, and now they're looking a little bit on the mottled side, okay? Not really working because the underlying cause hasn't been treated or can't be treated or whatever the situation is. So it sends out some more and more epinephrine. Blood pressure's still not great, really tachycardic because we got a lot of epinephrine, a lot of sympathetic nervous stimulation going on. So lots and lots. So now the fingers are even looking blue. Fingers, and of course it's all over. It's capillary beds everywhere, but in the peripheries especially, hands are all the way up. It's looking really blue and mottled, just really not looking well at all. So I know that I'm clamping down in my periphery, really clamping down in my periphery. Okay. So what happens is I've got poor blood flow going through my capillary beds. Really poor blood flow going through my capillary beds. So what happens is capillary beds say, I don't have very much blood down here. And I'm really getting some anaerobic metabolism starting because there's just poor blood flow going through here. Do you think you could send me some blood? And so what happens is your arterioles and your venules, the bigger side of the ones on the both sides of your capillary bed say, I hear you. So the arterioles say, I'll vasodilate just a little bit and give you some blood. I'll give you some blood. So they open up a little bit and let some blood go into the capillary beds. And then the brain says, no, you can't do that. That will drop the blood pressure. And so they throw some more epinephrine because the blood pressure, these things say, no, I need some more. The epinephrine gets shot out and those arterioles and venules slam shut. But we just let blood go into the capillary bed. So now I've got liquid blood in the capillary beds that now I've shut the gates on both sides. So what happens? Clotting factors are now clotting off that liquid blood in all your capillary beds. And they said, oh, please, can we not open and give me some more blood? I don't have any moving blood. They said, oh, well, okay. So they open up a little bit and let some blood in, and they said, no, you can't do that. Slam shut. Now I've got some liquid blood in there again. And so what happens? It starts to clot using clotting factors. And so it's kind of a little bit of open when they shouldn't because they're trying to compensate, but then the body says no. So they open up and let a little bit in when they shouldn't, but they did. And so what happens is you use, by opening it up a little here and opening it up a little there and opening it up a little here and opening it up a little there, they end up using up all of their clotting factors. So now I've got this patient that's used up all their clotting factors. So I go to put an NG tube down them and they have this massive nosebleed because there's nothing to stop that nosebleed, to stop them from bleeding because they have no clotting factors. I do a stick on them and I put the Tegaderm over and it just oozes blood under the Tegaderm all the time. They do an ABG on them and they can't get the artery to stop bleeding. No matter how long they hold it, it won't stop bleeding. Blood starts in their Foley because they're bleeding and they can't stop it. Their wound starts to ooze blood. There's no clotting factors to stop their blood. They've used them all up. There's no clotting factors. Okay, so what do we do? Their underlying problem is causing it. We'd like to stop it, first of all, whatever's causing it. Okay, we're going to monitor their labs, their PTs, their PTTs, their platelet counts, because you know thrombocytopenia also causes it. So I'd like to watch their platelet count. Their fibrinogen level, their D-dimers. I've talked about D-dimers before. D-dimer doesn't tell you, and their fibrin products, the same thing, doesn't tell you where their clot is. It simply says they have a coagulable problem going on. So their D-dimer and FSPs are going to be high, meaning they are in a hypercoagulable state. They have high clots in their body. It's all used up. They're all in their capillary beds. Okay? So the first thing we do, I got these patients oozing blood everywhere, is we put them on a heparin drip. And you think, heparin drip? They're bleeding. What a stupid doctor. I know more than that resident does. My patient's bleeding and they've ordered a heparin drip. What an idiot. They're not an idiot. Somebody unmute and tell me, what does heparin do to a clot?
Prevents it
Prevents it from what? I couldn't hear you.
getting bigger.
It prevents it from getting bigger. So when we put the patient that's in this case, that's bleeding on a heparin drip, when these venules and arterioles open up and some of that blood gets into that capillary beds and then slam shut, the clotting factors that are trying to build back up will not rush to it and start clotting. The heparin drip will prevent it from using up any clotting factors that are trying to build themselves back up. We put them on a heparin drip, trying to give the body time to build clotting factors without using them up. Because right now, every time they get something, the clotting factors are being used up, and therefore there's nothing to stop them from bleeding. So the heparin is to keep them from clotting so that they have time to have some clotting factors. Then we give them clotting factors. Clotting factors are located in fresh frozen plasma and cryoprecipitate. And hopefully treat their underlying cause that's causing their problems in the first place. So it seems kind of counterintuitive that you got somebody bleeding and you put them on heparin, but you got to think of why they're bleeding. They're bleeding because they can never build any clotting factors. So we've got to stop them from using their clotting factors so that they have time to build them back up, because they've used every bit of their clotting factors. So we put them on a heparin drip. I will tell you that most patients that go into DIC will not live. Some do, but most will not. It is so hard to reverse them. So hard to reverse them. And then the last stage is the refractory stage. This is pathophys. You know, there's two kinds of shock, of hypovolemic shock. There's external, where it like goes out on the ground. And then there's third spacing, like ones that go into your abdominal cavity. This is not that important. This is back to hypovolemic shock again. As always, the very young, the very old, and those with chronic illnesses do not do as well as those that are not very young, and those that do not have chronic illnesses, they just don't. Typically, if you have fluid loss of about 15%, which is about 750 mLs, you will compensate on your own. You don't even need treatment. At about 15 to 30% of your circulating blood volume, you will see dizziness and sympathetic nervous stimulation, and you will probably need, you'll probably just get tachycardic, probably just water at home would be fine. Between 30 and 40%, you need to, in the hospital with aggressive, that 3-to-1 volume replacement, and greater than 40%, and it will be bad news. Bad news. Now, we've already covered this. I'm not covering this again, but the problem is fluid volume deficit. So our goal is that the patient will have adequate circulating blood volume, go back to multiple trauma, and we already talked about adequate circulating blood volume. As with anything else, your priority is always airway, breathing, circulation. And this treatment is going to be usually under circulation. We're either going to give them crystalloids or transfusion of blood products. We can use whole blood, packed red blood cells, fresh frozen plasma, which will have clotting factors in it, or just plain platelets if all they need is platelets. I will tell you, the most common blood product you will ever give is packed red blood cells. I have never given whole blood. In my entire career, I've never given whole blood. If you work on an oncology unit, you probably will give more whole blood. They need more of the stuff in whole blood on oncology units. They need more of the immunoglobulin type things that are in whole blood. But most patients need the hemoglobin and the hematocrits, and the hemoglobin, not the hematocrits, the hemoglobin. And so most of the time you will give packed red blood cells. Now, I've given fresh frozen plasma and platelets for bleeding, but as far as blood and hemoglobins, you give packed red blood cells. You will give packed red blood cells more than anything else in your career. And then, of course, treat the underlying cause. So it's 12:51. I want y'all back here at 101. We're going to talk about how to give blood next. I know you don't give it as a student, but you still need to know how to administer blood and what to watch for. And then sepsis is what we're going to cover for the end. I'll see y'all back here at 101. And I'm going to go out for a minute because I'm going to try to get y'all's pictures back. But I will, I'm not going off forever, I promise. But I'll answer questions if anybody has any. No? Okay. Won't let me do it. Positive. Okay, so when we talk about blood administration, as a student, you cannot administer blood, and that has to do with insurance more than anything. But you once it's hung, once it's physically hung, you can monitor the patient, and you'll have an opportunity in the preceptorship. Just your preceptor will hang the blood, and then you can be right there with them. They just physically have to hang it, but you should watch them go through this process. Blood administration requires a physician's order. You can't make the decision to hang blood. But you always, when a physician orders blood, you should compare the clinical status of the patient and their lab values to the blood. Why are they giving them blood? Because, docs are not without their errors, and they could have written it on the wrong chart or whatever. So you always want to compare, why are they getting the blood? And if you can't come up with why, then maybe you should ask why. You want to explain the procedure to the client, and it could be the doctor or the nurse, but this is something that they're going to be getting blood on. And you want to obtain the consent. There's one consent per category. So if they're to get 1 unit of packed cells and 2 units of fresh frozen plasma, you have to get a consent for the packed cells and you have to get the consent for the plasma, but not for each unit of plasma, just for fresh frozen plasma. So there's one consent per product category. The OR consent form has that they would give consent to get a blood transfusion and for 2 hours post-op after their surgery. So that is included in the OR consent form. Blood for adults should be given through an 18 gauge or larger line. We can give it through a 20, but the larger the line, the better, because it doesn't break up the cells as much. It doesn't cause hemolysis quite as much. So you should always make sure you have a good patent line and make sure your line is in before you order the blood from the blood bank. So if you go in there and you don't have a line or it's not patent, then get your line started and then get your blood from the blood bank. There's lots of ways to do this, and it's all depending on where the patient is in the ER versus up on the floors, and even from different hospitals. So they may have a blood bank bracelet. They may just have their regular bracelet. But all of them should have a blood bank number on it. And BB stands for blood bank number type thing. And so this is an example of a blood bank bracelet. And this is just like their hospital bracelet type of thing. And so they'll have a blood bank number on it. And you can see down here, pointer up there. This is their blood bank number, the BB number right here. And CC stands for Carolinas Medical Center. It would be an M for Mercy. It's a P for Pineville. I think it's a U for University, I think. But BB number means blood bank number. And that's the number that you need to get the blood from the blood bank type thing. If the patient has no armband on at all, then they have to be retyped and crossed. So like, let's say they had an ER blood band on because they didn't have a bracelet for the hospital on yet. And when they came up, you cut that off and put a hospital on one that was on there, but their blood was typed and crossed to their band from the emergency department. You cannot say, well, they had it done down there. It has to be a bracelet they have on. So they would have to be typed and crossed again. Anybody can take can go down and pick up the blood. It does not take a registered nurse to get the blood. So all you do is get the patient's number and put a little tag, put a little stickies on it, and a tech can go down and get the blood from the blood bank and transport it back up to the unit. Anybody can bring the blood up. So when you're going to get ready to give blood, you should have a set of vital signs, and they can be done by anyone at least 15 minutes before you start the blood, but not longer than 15 minutes before you start the blood. So if you're going to get blood at 9:30 in the morning and the vital signs were taken at 7, that's too far out. You've got to get blood right before. But if it's 8 o'clock and they were done at 7:45, that's close enough. So really they should be done about 15 minutes before the blood is started when you get ready to do this. Make sure you have an order for the blood. And were there any specifics? Most of the time, the order will just be transfuse 2 units of blood, but there might be ones or transfer 2 units of packed red blood cells. They might say over 4 hours or over 2 hours, or they probably won't, but they might say at 50 mLs an hour, but they probably won't give a rate. They'll probably tell you to give it over a certain amount of time, or they may not tell you that at all. If they don't give you a rate, then you need to figure out what is the correct clinical picture for your patient. So if they have an IV that's going at 50 an hour, then I would run my blood at 50 an hour, because that's pretty much what their fluid rate is. But you need to make a clinical decision on how fast you're going to run the blood based on your patient. 2 licensed individuals must go into the client's room and check the blood. Now, an LPN is a licensed individual. The LPN cannot start the blood, but an LPN can check the blood with you as a registered nurse. Now, our blood bank at CMC, I can't speak for the other hospitals. It's not the fact that we have EMARs. That is not the point. It is the blood bank. If your blood bank has electronic checking and you can scan the blood, they can be your second checker. So it's you and the scanner. Then it only takes one person to check the blood. The scanner will be your second checker. But if your blood bank does not have a scanning system, then it takes 2 licensed individuals to check the blood. Okay, so this blood doesn't, but this is not real blood, by the way. This blood will have a label on it, and there will be a piece of paper that accompanies the blood from the blood bank. So you start out by checking the blood and checking the patient, all right? And so the paper will have, one person will have the patient's armband, and one person will have the blood. And one person will say, I have the paper with the blood, and the person will read from the person's armband, and they'll say, this is John Smith, number 764231, 764231, date of birth 12/4/64, 12/4/64, that kind of information. They're going to read that. Then the person that has the paper hands the blood to the person, and the person with the paper or the blood, either one, says, this is AB negative. And the person says, this is AB negative. Unit number WO44111126636. Unit number, I read back, WO44111126636. And we both agree, because we read it twice to each other, that this is the correct unit of blood on this paper and this. We've already verified the person. Now we're verifying the blood. We've said both the blood type, we've said the unit number, and the expiration date. This blood expired on March the 9th, 2012. So we wouldn't be given this, but if it was 2022 or whatever it was, we want to make sure the blood has not expired and that we are giving red blood cells. This is red blood cells. Okay. So we now agree. So that person's going to sign under the witness. I'm going to be the transfusionist. So I'm going to come up and sign under the transfusionist, and they're going to go over to the MAR and sign up that they are the witness. All right. So now it's now time. So we both sign the requisition. We both sign. They'll sign under the witness. Now, blood is only compatible with normal saline. Right. So I'm going to go in and I'm going to go, and the blood will come with its own tubing, and it'll come with a special filter inside the tubing. It'll be in a box. Okay, so there's the spike, there's the filter, there's the tubing, and the tubing is pretty short. I don't know if you can see how short that tubing. It's not very long, maybe 2 feet at the most. It's short tubing. It's almost like a secondary tubing. It is a secondary tubing, actually. Okay, it is secondary tubing, but it looks different. Okay, so what you do is you pull off either one of these white, probably the one that's empty, sort of, one of these white caps. Upside down, you spike your tubing, and you squeeze your blood up until it comes up about halfway past your filter. Okay. Now, as always, the first thing I did was clamp my tubing. I don't care what you're opening. That should be your first step every time you get ready to prime tubing, is you close your filter, close your clamps. Okay. So the first thing I did was close my clamp, spike my tubing, squeeze my blood up until it's about halfway up my filter, turn it upside down. Now I can open my clamp and I will fill my tubing. I have not a drop of air in my tubing. If you don't close your clamps, you'll get air in your tubing. I don't care what your tubing is. I don't care what you're doing. Okay. So that's how you prime your tubing. All right. Now, when you prime this, your other primary set on your Alaris, your primary set is going to be normal saline. You're going to prime your primary set with normal saline. Blood is only compatible with normal saline. It's not compatible with lactated ringers. It's not compatible with a PCA pump. If you have to give an IV push med, you cannot push an IV push med through blood. You can give nothing with blood except for normal saline. Now I have a primary of normal saline, and I've got to give a secondary of blood. I think I've told you all wrong if you want to know the truth. I don't know how this plugs into the Alaris. So the Alaris pump might have different tubing than this. I'm not sure. But however this gets plugged into your Alaris tubing, I'm not exactly sure where it is. So when you're in the preceptorship, they'll show you exactly where it goes, okay? When it plugs in, before you put it on the patient, you put the two together, the normal saline and the blood together on the line, and then you prime it more. You prime it by gravity down to the blood at the hub of the tubing. So if this was secondary, you've still got a primary tubing that's this long that has saline in it, right? You want to just go on and open up your primary and let that blood come on down your tubing until it's at the very end of your tubing. And then clamp it off. Then plug it into your patient with the blood right ready to start. This might not be, I need to check that. This might not be what the blood tubing looks like now that I think about it. Okay, why is that? Because of this next bullet. Licensed personnel must stay with the client during the first 15 minutes of the transfusion looking for signs of a blood transfusion. If they're going at 50 an hour, that blood won't get to the patient if you start up here for at least 30 minutes. So you have to wait 30 minutes, not leaving the room until that first 15. You got to stay there until the patient gets 15 minutes of blood. So you want the blood to be right there and the blood ready to start. You want the blood to be right at the end of your tubing. ready to start, not somewhere up in your tubing up here. But once the blood starts in on your patient, you have to stay, the RN has to stay in the room. You can't go out and answer the telephone. You can't go out and give somebody pain medicine. You can't go out and do anything. You must stay in the room. If you have another patient arrest, someone else has to go do the arrest, has to go do the code. You have to stay in the room for 15 minutes with your patient. At the end of 15 minutes, you must take a complete set of vital signs, including a temp. If there is no signs of a transfusion reaction, you can now leave the room. And another set of vital signs can be taken by anybody at the completion of the transfusion. So there's vital signs before the transfusion starts, vital signs by the registered nurse 15 minutes into the transfusion, and vital signs at the completion of the transfusion and 30 minutes after the transfusion. And those can be done by anyone, tech, nurse, anybody. Okay.
Hey, Janie.
Yes.
Maybe I was looking at an old PowerPoint, but I also have a bullet point that says take vital signs at the end of 1 hour and then hourly until the blood is completed.
That's an old policy. That is an old policy. That is not what's done now. Okay. Okay, so it's just a few additional information. You start your blood as soon as you get it. Do not send it from the blood bank if you're not ready to do it, okay? If it's been out of the blood bank for greater than 20 minutes, the blood bank will not take it back. Right? Do not put it in your unit refrigerator. It needs to be in the patient in 4 hours. So if it's going to be going a unit really slow, then tell the blood bank you only want half the unit. And then when you get that half in, have them send you the other half. But it can only hang on the pole for 4 hours. It has to be in the patient within 4 hours, totally. When you're done, it just simply goes in the trash can, just like any other IV fluid bag would go, unless they have a reaction. In that case, it'll go back to the blood bank, which we're going to talk about next. But if you don't have a reaction, you just dispose of it like you would any other biohazard type thing. Compatible only with normal saline, and the filter is good for 4 hours or 4 units. If you're in the ER and you're giving blood push, you can hang 4 units on the same tubing, and then you got to hang a new one for every 4 units. Or it can hang for 4 hours, and then you got to have a new filter. So what type of blood transfusion reactions are there? Well, the worst, and the one that's pretty much deadly, is an ABO incompatibility. ABO incompatibility, it's a transfusion reaction. This means the patient got the wrong type of blood. And that will make their blood cells, not just the unit they got, but all their blood cells start to burst. Hemolytic, breaks the cell wall. They will have a fever. It'll go up about 1.8 degrees of where they started. They will be chills and flushing. And these broken cell walls, blood cells will start to plug the kidneys. So they will have hematuria and low back pain, flank pain, CVA tenderness, where the costovertebral angle, CVA, where the kidneys are in their flank. And that's all because their kidneys are being plugged up with dead red blood cells. They will become tachycardic and hypotensive and tachypnic because they don't have red blood cells to carry oxygen. And these people will develop acute renal failure, and they will go into shock, and they will die. Giving blood is a serious matter, and you need to do it seriously and make sure you're giving correct blood types to your patients. It's pretty much a death sentence if you give the wrong blood type. Now, most patients that have a transfusion reaction do not have a hemolytic reaction. They have a febrile reaction. They have an allergic reaction. That is not deadly. They simply are allergic to something in the patient's blood. And they get a headache, they get a fever, they might get itching, they might feel like kind of flu-like symptoms. And usually a little Benadryl or a little Tylenol will make them feel better. But they do not have the renal symptoms. The cells are not bursting. They're simply having an itching and an allergic reaction to it. So we treat the allergic reaction. And then the third ones are things that happen way down the road, like they might get AIDS from blood or they might get hepatitis from blood. We do everything in the world. The blood bank screens very well, but there are disreputable people out there. There are disreputable blood banks out there. But CMC is not one of them. Atrium Health is not one of them. But there are hospitals that get their blood from places that aren't as reputable. And you can catch stuff from them. So what do you do if you suspect a transfusion reaction? You stop the blood. Whether it's febrile, whether it's hemolytic, stop it. Don't give any more of it. Hang normal saline to your IV site. Plain normal saline. Don't discontinue your site. We need that site. You notify the doctor and you notify the blood bank, because the blood bank's going to start immediately doing some type and cross and some type and antibody tests to see what they might have been allergic to in that blood, because they still have that patient's blood type down there, and they're going to start running tests on the blood and trying to match those bloods up again. Recheck all your numbers. Make sure you really had the right blood, the right numbers. Recheck all your numbers again. Recheck the vital signs on your patient. Make sure your patient is okay. Monitor their urine output, because if it's hemolytic, it's urine that's going to be affected the most. We're going to treat their symptoms per their doctor's orders. So the doctor's going to order Tylenol. The doctor's going to order Benadryl. The doctor's going to order hydrocortisone IV push. Going to order all types of orders. The blood bank is going to order tons of labs, and they're going to order tons of urine tests. The doctor's going to say, send down all the labs the blood bank says to send to them. On the computer, there will be one under care events. There will be a transfusion reaction form you got to fill out. And then you're going to document the status of your patient in your EMR, not your EMR, in your electronic charting. And watch your patient. Chances are they'll be okay as long as it wasn't hemolytic, as long as you didn't give the wrong blood. And that's pretty rare. It's pretty rare. Most of them will be febrile. And Benadryl, steroid, and Tylenol will pretty much take care of it. I don't want to make light of it, but you want to be careful before you give it, that you don't give the wrong blood. That's the biggest thing. Okay, last section. I don't know if you've heard of SIRS, though this isn't SARS, this is SIRS. Systemic inflammatory response syndrome. Systemic inflammatory response syndrome is basically what we sort of see as we are progressing into sepsis, all right? It can be seen with any underperfused state. We can get it due to any of the causative agents, right? And typically, we're going to have two or more of the following vital sign changes. They're either going to become hypothermic or hyperthermic. They're going to become tachycardic. They're going to be tachypnic, and they're going to blow off their CO2. So they're going to be they're going to have a low CO2. They're going to be hypocapnic. And usually they have a white count, but they can have a high white count, but they can be low. So, and then they can go into multi-system organ failure. And we're going to talk about all this right now, but we're really talking about people that are going to go into sepsis. So here's all your different kinds of shock at the top that we've talked about. And what happens with these type of shocks and with SIRS is they will release we call them a mediator. They will release a neurotoxin, an endotoxin. Now, these endotoxins are bacteria. It doesn't have to be a bacteria. It could be just a chemical. It doesn't have to be a bacteria, but often it can. It can be a bacteria. And so what does that bacteria do? And if you get down here, it causes widespread endothelial injury and dysfunction. What is that? That's words that mean a change in the permeability of the capillary bed. I've said those words before. It makes the holes of the capillary beds big. In burns, it was due to heat. In neurogenic, it was due to parasympathetic stimulation or transection of the spinal cord. Okay. In this case, it's due to an endotoxin, probably a bacteria, but not always, but probably a bacteria. And in this case, the capillary beds got big and fluid went out of the circulating blood volume, and therefore your tissues became underperfused. Your brain became underperfused, your heart became underperfused, your lungs became underperfused, your kidneys became underperfused, your major organs became underperfused, and you were in shock. What kind of shock were you in? Because it was from an endotoxin, it was septic shock. They're all an underperfused state. What was the cause? In this case, infection, usually. The most common cause of septic shock is either gram-negative or gram-positives, typically strep and staph. Those are the two most common. Is it the only one? No, it's not the only one, but by far it's the most common, strep and staph, okay? It says right, the invading bacteria multiply faster than the body can kill it. And it develops endotoxins. This damages the cells. And they release these endotoxins like histamine. And this causes increased capillary permeability. Holes get big. Fluid goes out of the circulating blood volume. Underperfused. And now major organs are going to start to die. And they develop the loss of major organs. When you lose 2 or more organs, it is called multiple, well, different people would call it different things, okay? The latest is MODS, M-O-D-S, multiple organ dysfunction syndrome, multiple organ dysfunction syndrome. That's MODS, M-O-D-S. Other people will call it MSOF, multi-system organ failure. They're the same thing. So if you see MSOF or MODS, they are the same thing. It's depending what book you pick up. Both of them mean dysfunction of 2 or more organs. And it's all because of impaired perfusion to the organs. Okay. Why? Because they had a bacteria, an endotoxin release. Most commonly a bacteria. It doesn't have to, but it's an endotoxin. It's something. It could be a virus, not very often. It could be something besides the gram-negative and gram-positive. It could be a Klebsiella or something, but as a whole, it's usually gram-negative or gram-positive most of the time. Some typical nursing diagnoses. The lungs are often affected, so we often have impaired gas exchange. We know we have impaired tissue perfusion because that's the definition of shock. Not enough blood flow to the organs. Altered thermoregulation, they have either a high temperature or a low temperature. Not enough perfusion to the brain, and they're not thinking well. They're confused. Anxiety and fear. you're really, 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 really sick. And anticipatory grieving. A lot of people from sepsis die. My father died of septic shock after a ruptured valve, peritonitis. He died of septic shock. So, I mean, there's once it happens, it's hard to get people out of it. Very hard to get out of it. So what do we do? Well, first of all, don't let them get in septic shock. We as healthcare providers can work on prevention. Know the population at risk. Anybody want to guess who's at risk?
People that are immunosuppressed.
That's one. Anybody know another one?
Diabetics.
They're at risk. Anybody know another one?
Elderly.
The very old.
The
The very young.
Chronic conditions.
And those with chronic conditions. Very good. I mean, they are always the ones that are at greatest risk. So, the diabetic was good. That's good. The ones with COPD are good. But the very old, the very young, and those with chronic conditions, they are the population at risk. They're always the one. Getting a thorough history. Again, what type of things are wrong with them? It's very important. Using sterile technique. You have been taught sterile technique, and you should use it. I don't know if I've told y'all this story or not, but I was up on one of the units with students, and it's a unit, and one of our past students is in there doing a dressing and I'm in there with them, with the student. We walked in. She's packing a wound, and probably her arm is in this deep, packing a wound, and she's using clean gloves. After it was over, I said, I want to talk to you at home. And I said, you packed that guy's wound with clean gloves. You did not put on sterile gloves. She said, I know, Janie, but on this unit, we really don't use sterile gloves. And I looked at her and I said, I taught you better than that. You are in this guy's abdominal cavity, packing his wound. And you don't think that's a sterile procedure? I know, but we just don't bother with that. I said, if that was your child, would you think you would have used sterile gloves? She said, well, I probably would. I said, then by God, you put sterile gloves on your hands. I said, I taught you better than that. I am ashamed of you. And she just sort of dropped her head. Now, I don't know if I loosed her, but by golly, you all know, it takes just as much time to do it right as it does to do it wrong. And I mean it. I know you will hear it over and over and over. They teach you that way in nursing school, but you really don't do it that way. That is a bunch of bull-locky. You do it that way. There are shortcuts. There's not a doubt there are shortcuts. But there are certain shortcuts you cannot break, and sterility is one of them. I mean, and all I can say is when you get ready to break one and you know you're breaking it, you put your child's face on that patient's face, and you say, would I do this if this was my child? But I used to say if this was your husband, and I knew you'd let your husband die. So now I say your child. Okay. So just, that's what I want you to do. Okay. I'm moving on. Standard precautions, so we're not passing things back and forth, and to keep assessing your patient. Another thing that stops the release of endotoxins is early nutrition. Early nutrition. We'll talk more about it in just a minute. So, oxygenation and ventilation if they need it, ABCs. If they're breathing well on their own, they might not need that. But if they have poor perfusion or poor perfusion to their lungs and they need ventilatory support, that's one of the organs that needs support, then we've got to give them their airway, their breathing. We've got to do it. We're going to monitor their hemodynamic findings. Hemodynamic means blood vital signs. What's their pulse rate? What's their blood pressure? If they've got internal monitoring like an ART line or a CVP or a Swan-Ganz in, what are those findings? And what do they mean? And how are they doing? Give them their IV fluids. It's a C problem. It's a perfusion problem. Monitor their IV fluids. and give it at the right rate and correlate it to what were their hemodynamic findings. You know, do they need more? Do they need less? What is their urine output? Do they have enough? Do they need more? If you are a nurse that says, well, the doctor didn't order it, you are not a nurse. You are not a nurse. Go back and put tech behind your name and get out. That is not a nurse. You ought to be the one saying, this isn't right. I got to do something about this. That is not a nurse. That's a tech. Daily weights, best indicator of fluid balance in the body. Step on the scales today, you weigh 150. Step on the scales tomorrow, you weigh 155. You did not put on 5 pounds of fat in one day. That's fluid. Step on the scales today, you weigh 150. Step on the scales tomorrow, you weigh 145. You did not lose 5 pounds of fat in one day. That is fluid. Okay. Keep a watch on your lab values. You know that when you get dry, your lab values tend to go up. Fluid balance and lab values have something to go together. And this is a perfusion problem. It's a fluid problem. You want to get your culture and sensitivities as fast as possible because the key, it's caused by a bacteria. The key is to get your antibiotics started as fast as possible. The antibiotics is one of the things that will stop your endotoxins. Stop your endotoxins, you close your capillary beds. That stops the fluid from leaving your circulating blood volume. Stops the change in your perfusion. But you need to get your blood cultures first. You need to get your wound culture first. You need to get your urine culture first. You need to get your sputum cultures first, as fast as you can get them. And then get your antibiotics started as fast as possible. And any other pharmacological inventions. If they need vasopressors to get their blood pressure up, like your dopamines and your vasopressin, then you're going to have to do that too. Because it is ABCs. So we do have to look at, do they need something to get their blood pressure up? Do they need something that going to help them hemodynamically? So other pharmacological interventions are also very, very important, right? And then nutritional support. Antibiotics can stop the release of the endotoxins, but nutrition is also essential for the stopping of the endotoxins. Now, I'm gonna tell you a little story. I only have one more slide and it looks like my time is pretty good. So I'm gonna tell, usually I don't always get to tell the story. When my father had his incident, my father was 85 when he died, I think. And he broke his hip and did really well post-hip and was at home, had just had physical therapy, was sitting in his chair at home and had threw a clot to his bowel and killed his entire bowel. And they called me. I had just flown up to my daughters in Minnesota. They just moved there and they said, you need to come immediately to Kentucky. And so I got on a plane, took me all night. I slept in Detroit airport, but I came home and they'd already rushed him to surgery, of course. And when I got back, he was really, really bad, really, really, really bad. So he'd gone into septic shock, of course, because he had peritonitis. And we went to the hospital where I had been a nurse manager and I knew this hospital well, very, very, very well. I knew this hospital. So I was sitting in ICU by his bedside and I don't know if this was the next day or a day after that. And he was in septic shock and all. And so my brother, who is an engineer, who is, he's like a CEO sort of guy of a company. And, he knows all there is to know about everything. So and remember, my dad has no bowel. Okay. He has no bowel. And so the docs are making rounds that morning because it's a teaching hospital and it's a little different. You can't have a private doctor there. You have an attending, but you can't have a private doctor. And so they're rounding about 5 o'clock in the morning and I'm sitting there and they get through with their rounds and they say, hello, do you all have any questions? And I said, yes, I do. And they said, what's your question? I said, when are you going to start TPN on him? And the doc sort of looked at me kind of funny and they said, well, I don't know that, we want to do TPN. And I said, well, being in septic shock, you got to get him some nutrition started because nutrition's really needed to stop the endotoxins. And so I know he's on antibiotics, but I really think we got to get a central line in him and get some TPN started on him. And of course, the docs kind of looked at each other like, who is this woman sitting here, And of course, my brother. Now, Janie, these are physicians and you need to listen to them. And I said, oh, one finger went down. And I was like, just leave me alone. I said, I just want to know, when do you all plan on doing TPN on him? And the doc said, well, we really don't have any plans. And I said, all right. So I knew that this was the last day of the month. And I knew on the first day of the month, my attending was going to change. So later that afternoon, the attending came up to me and he said, who are you? And I told him what I did. I said, I teach nursing, And he said, you know what you're talking about. And I said, I do know what I'm talking about. He says, well, services change in the morning. He said, I can't give you TPN. He said, but Dr. So-and-so is going to be your attending in the morning, and he will give you TPN if you ask him. He will give it to you. And so the next morning, by 5 o'clock, I'm sitting there, and Dr. So-and-so comes in, and he said, you're the nursing instructor. And I said, I am. And he said, and you want TPN? I said, I do. And he says, my resident will be back about 10 o'clock and get your central line started, and TPN will get started on your dad. And I said, thank you. And so I would say by midnight, my dad was awake, and he knew he was intubated, but he knew exactly what was going on. He could respond to commands, and he'd been unresponsive for the last 3 days. And by that time, his fever was down, his white count had started coming down, his blood pressure was better, and he was awake by probably that evening. And we actually got him extubated, but he lived another year, but he was never really good. And after that, my brother would say, ask my sister will answer all your questions. But after that point, he was in charge, you understand. But, I just really was saying, you got to get nutritional support going on them. You just have to. So just to finish up in the last few minutes, so other interventions, we don't want to overuse their energy. So it should be calm and quiet. So they've got to be able to regenerate their tissues. We do not want them to go into anaerobic metabolism. So, we want to decrease their myocardial oxygen demand. So we want to have good oxygen going on these patients. We don't want to overwork them, moving them to a chair as they're progressing. So we don't want to get them up and have real vigorous exercises starting out as they're getting better. We don't want them to be real tachycardic. So we want them to recover slowly from septic shock, because we do not want them to get a bacteria that we can't treat very well. And anaerobic bacteria is really, really hard to treat. So we want to stay with aerobic bacteria. Keep assessing them very, very thoroughly. Like for breakdown or anywhere else that might get infected. So you want to really watch for early signs of infection so we can treat them very quickly. Sepsis is hard to treat. Many patients do not come out of it. And even though my dad came out of it, he still was very, very ill, and he ended up dying. But many patients do not come out of it. And so a lot of emotional support, a lot of anticipatory grieving for families, and long hospitalizations and expensive hospitalizations. And they're very weak. They have multi-system problems. So, all the problems of immobility and long hospitalizations of skin breakdown and contractures and foot drop and just pneumonias and all the other problems that come with long hospitalizations that are very, very, very difficult for families. Sepsis is very, very difficult and often is not recovered from. Often is not recovered from. So if I could give you a clue type of things, because I have about 5 minutes and I'm never finished early. So let me give you a few clues along the road. Make sure you look at the causative agent, okay? And I don't know if it's on the test. I haven't seen the test, so I don't know what's on the test. But, if I was to say that they were, if they were in a car accident or they were in a swimming pool accident and they broke their neck, and they were hypotensive and bradycardic, what kind of unmute? What kind of shock would you expect them to be in? Neurogenic. If they have pus coming out of their toe and they have a fever of 102, what kind of shock are they in? Septic shock. If they were in a car accident with a hemoglobin of 8, what kind of shock are they in? Hemorrhagic. Exactly. If they got stung by a wasp, you don't know this yet. What kind of shock are they in?
Anaphylactic.
You don't know that. It's anaphylactic yet. Yeah. Because there would have been an antibody antigen reaction. You'll learn that on Tuesday. And I probably would give you vital signs showing abnormal vital signs with it. But you want to pay attention to the causative agent. Now, one other little clue about prioritizing with trauma. You're going to make sure that you get your little whiteboard out and you're going to say, which of these following is your highest priority? And you're going to write 1, 2, 3, 4, A, B, C, D, whatever it is on ExamSoft. And you're going to say, oh, patient with substernal chest pain radiating down their left arm. Number 1. That's a heart attack. That's a pumper. That's a C. 1 is a C. A infant who has a fever of 104. It's not airway. It's not breathing. It's not circulatory. It's not D. That's a nothing. That's not an A, B, C, or D. A person with a open tib fib fracture that's bleeding. That's a C. Bleeding. That's a C. A child who fell or a child who has asthma and has expiratory wheezing. Wheezing, that's airway, that's A. I got 2 C's, a nothing, and an A. The one with the highest priority is the A. You do it that way. You don't sit there and say, oh, but it's a baby with a fever. I don't care. I do care, but I don't. That's how you do your priorities. Okay? I'm done. I will answer questions if anybody has any questions, but I'm done. You can sign off or you can stay here and ask me questions, whatever you want. Anybody?
At CMC Maine, do you guys have like septic protocol where you have to give antibiotics within an hour?
I don't know what the latest protocol. They do have code sepsis that does have protocol. I do not know. Hey, anybody that works at Maine, do you know? I don't know if it has a specific time frame on their code sepsis or not. Do you know?
I'm pretty sure it's an hour.
Yeah. So they have to get their labs drawn. I bet they get them in even before an hour. I bet you.
Yeah, that's what we do at Pineville, but I didn't know if it was a hospital by hospital basis, depending on how long you connect, like how good the pharmacy is. Oh,
we can get ours pretty fast. I guarantee you.
Yeah. Yeah, I'm assuming y'all get y'all stuff faster than we do.
I don't know. I guess I can answer that question.
Yeah, and we actually have like an ED pharmacist now at Maine too, so stuff gets done
that's cool.
like that.
Mm-hmm. I would say we do, but I just didn't know what the time frame was. But we do have code sepsis, we have code strokes, we have all sorts of kind of different codes for different situations with pre-standing orders. So you're not sitting around waiting for specific orders. Again, it's a standardization of care so that nothing's missed. Yes.
When it comes to so since all kinds of shock are considered an underperfused state, the underlying goal is going to be to normalize the or get their perfusion up. So every kind of shock is going to be treated as a fluid volume deficit, correct?
No, that is not true. It's under perfused, but it could be under perfused for something other than fluid volume, like cardiogenic. Cardiogenic, you don't lose fluid. Your pumper is not pushing it forward. If you give fluid in cardiogenic shock, you'll kill the patient, which you haven't had yet. Jane will be covering that. So no, giving fluid is not the answer in all shocks, no. And even in anaphylactic, fluid isn't the answer. It's to stop the antibody antigen reaction. I mean, you can give fluid, but it's not the treatment. Okay. So no, I would not say it's really and truly you want to stop if we can, to stop the problem. Now with hemorrhagic and with hypovolemic, we often can't stop that problem very quickly. I mean, they could be rushed to the OR, but they might die in the time. So giving them fluid, the answer is yes. The answer is yes. Cardiogenic, the answer is no. Neurogenic, fluids are okay, but positioning is better. We can give them fluid, but we don't have to give them that huge amount of fluid. We can just position them so that a little blood's dumped back in their head, back in their body. What was it? Septic. You have to watch septic, giving them a lot of fluid, because a lot of times if they go into respiratory failure, you have to watch giving them a lot of fluid too, because they'll drown. Or even cardiac failure. They can go into cardiac failure. So fluid is not always the answer for impaired tissue perfusion. Treating the underlying cause is really the treatment. Why are they in impaired tissue perfusion? That's really the better answer for you. And fluid might be the treatment, but it might not. And it's definitely not the treatment for cardiogenic shock. Absolutely not the answer. It's contraindicated. It was funny, this little story. Years ago, we had, it was when Driving Miss Daisy was popular, so that should tell you how long ago this was. But there was a busload of elderly people from Mooresville, from like a Mooresville assisted living, that had come to Charlotte to see the movie Driving Miss Daisy. Now, why I know that, I don't know, but I do know that. And on the way back to Mooresville, their van had wrecked. And they all were brought into CMC, and they had all significant injuries, like bad. All of them had bilateral hip fractures and, bad orthopedics and other pelvic fractures and things like that, because they were old. Us old people, we have problems. And so it was sort of funny, because they all were like hypotensive and not doing well when they got there. And so I remember I worked that night, and I remember the docs are saying, this patient doesn't have any P waves. Do you think they ever have P waves? Because we didn't know their cardiac status, but they were old. I mean, these people were 90s. We're sitting there going, do you think they don't have P waves from the wreck, or do you think they never have P waves? And then one person's blood pressure was really down. Do you think they're hypovolemic, or do you think they're cardiogenic? Because they're old, Nobody knew what was wrong with you. And so I remember this one patient really wasn't doing well. They kept saying, we don't know if this is hypovolemic or cardiogenic. And so they said, well, here's what we're going to do. All right, Janie said, go get me get the normal saline, and then go get about 100 to 50 of Lasix. So we're going to give her a 500 cc bolus. If she's better, we were right. If she's wrong, we're going to give her 150 Lasix and diurese off that bolus we just gave her and see if that helps her. I mean, it was just like, let's see what we do. We'll go with because of a wreck, we'll go with hypovolemic, and if that doesn't work, we're going to have to diurese it off, or we're going to kill her. I mean, you just go with what you think is best. So, and I can't remember what helped her. I can't remember which one we did. I just remember getting ready for both of them. I can't remember after that. Okay, other questions?
Thank you, Janie.
All right, nothing else? See y'all Tuesday. It's my last class I teach. Last class. Last class for love. I guess I have to stop recording so y'all don't hear me sing. Yes.